Hello, everybody. I want to welcome all the participants of the first Interasma Global Asthma Association seminar for the season 2021-2022. I want to thank Interasma for the invitation to moderate this session. Our speaker today is Professor Ignacio Ansotegui. He's going to be talking about allergy and airways from the evaluation to treatment. Professor Ansotegui is from the Department of Allergy and Immunology at the Hospital Quirosalud Vizcaya in Bilbao, Spain. He's past president of the World Allergy Organization, and he's president of Southern European Allergy Societies, and he is currently the treasurer of the Global Asthma Association, Interasma. It's my pleasure to have Professor Ansotegui talking right now.
Thank you very much, Professor Rosario Filio. It's a great pleasure to participate in these Interasma webinars. And the title of my presentation is Allergy and Airways, Evaluation and Treatments. Well, this is my conflict of interest. And in this presentation, we will just talk about the allergy sensitization and the immune response, main concepts of allergy diagnosis, methods in allergy diagnosis, importance of allergy diagnosis in precision medicine, personalized medicine in allergic respiratory diseases, allergen immunotherapy, a prototype of personalized medicine. Well, we know that in the underlying mechanisms in allergy sensitization, we have the exposure to different allergens and different environmental factors. And these allergens are captured by the antigen-presenting cell. And according with the profile of cytokines that the T cells produce, if they are mainly IL-4, IL-5, they will induce the switch on B cells to produce IgE isotype. And this specific IgE to the allergen will be bound to the cell surface of mast cells and basophils. But not only the allergens, also the other factors stimulate several mechanisms in the epithelial membrane, and also will induce the induction of alarmins that will increase the effect, and with activation of other cells will also enhance the production of the cytokines that are in favor of T2 prototype or T2 type, and will enhance the sensitization. Later, when we have the contact again of the allergen with the immune system, these allergens produce the cross-link of the IgEs that are on the cell surface of mast cells and basophils, and then will also activate those cells and induce the degranulation. And in this degranulation, it will be produced histamine, TNF-alpha, proteases, and heparin that will be responsible of the nasal symptoms like sneezing, nasal congestion, nasal ocular pruritus, and watery nose. After a few minutes, there is also the release of lipid mediators, prostaglandins, PAF, leukotrienes, that will be responsible of the first respiratory symptoms like the wheezing and the bronchoconstriction. Later, after hours, it will be the release of cytokines and chemokines that will be responsible of the mucus secretion and also the eosinophil recruitment. This is the acute phase, but there is also another phase that is chronic phase, also with the first activation with the allergens, that at the end, what we'll do is activate the specific memory T cells and induce new mediators that will activate effector cells, will increase the adhesiveness and vascular permeability, will mainly the IL-5 induce eosinophil infiltration, also enhance the local Ig production, and the IL-13 will increase the bronchial small muscle contraction, and also there will be an increase in the mucus secretion. Well, those are responsible of the bronchial hyperreactivity, also the bronchial remodeling, and of course there is a factor to have a persistence of the symptoms and also the presence of exacerbations. But before, when we were just reading the immunology books, actually the innate immune system was just a page. But in the last 2 decades, actually the innate lymphoid cells and the innate immune system has been much more developed, and also the knowledge. So we are able to see that there are cells that are very similar to the Th2, but those cells are not from the adaptive immune system, are from the innate. And these cells, as you can see, produce almost the same molecules or the same mediators that are released by the Th2 lymphocytes. So, but these IL-2 cells, there is one difference. They are not activated by the allergens. They are activated by the alarmins that are produced in the epithelial cell membrane, and those will activate those cells that enhance the production of IL-4 and IL-13, and also will help the Th2 to produce all the effects that we have seen. So we have to say that eosinophilic asthma is not always allergic, and we have two mechanisms of eosinophilic asthma. One mediated, that is the allergy one, by Th2, and the other one that is mainly mediated by ILC2. So, and this is just the difference, but both are doing exactly the same at the end. That's why it's more appropriate that we talk about T2 inflammation. So we could here more or less the same slide, in which we can differentiate in one part the activator is the allergen, and the other one are the different environmental factors. So we know for this reason that pollution, so environmental factors plus allergen, it will increase the sensitization. Of course, in those subjects that are genetically have genetically susceptibility, specifically to this developed allergy, what we know as atopic. When they have the co-exposure of allergen and pollutants, they will have a decrement of the epithelial skin barrier function, an increment of the oxidative stress, genetic changes, and also an increase of the Th2, Th17 response. And at the end, what we will have is an increased sensitization with more symptoms of asthma, allergic rhinitis, and other allergic conditions. So we could say that when we have the genetic predisposition in the presence of the allergen, we will increase the sensitization. In the presence of the allergen, we will increase the oral hyperresponsiveness. And in the presence of the allergen, we will have the disease. Well, several factors have been removed that before were discussed, and this is part of the hygiene theory, where we remove some protective factors like endotoxins or infections, and we have other enhancers not only for the sensitization, but also for the increment of the symptoms, and mainly is the pollution. Well, everything has been recently reviewed in this article, that is the interrelationship between the air pollution with the allergens, just helping in the inflammation of the airways disease. Well, for diagnosing allergy, what is the most important thing? Without doubt is the clinical history. Probably at the first care unit, clinical history with some physical examination and some diagnostic tests. The most important thing is just to distinguish which patient is allergic from which patient is not allergic. But when they arrive to an allergy unit, an allergy department, we do much more deeper clinical history, the physical examination. We can perform a specific diagnostic tests, looking at the etiology, also some functional tests that actually will help for the management and the specific treatment. And usually for allergy, we have three major branches, that is the allergen avoidance and education of the patient, the treatment of the symptoms with the pharmacology, and also combining always all three when it's indicate the immunotherapy. But which is the goal of allergy diagnosis? Well, to identify which is the causative allergen. This is the most important, and this is what we are talking today. Actually, for the diagnostic test in allergy, here we have very resume, and we have the skin test, that we have the skin prick test. Also, we could add here the intradermal reaction. We also could add here even delay allergy or delay contact dermatitis, just checking by a patch test. And we also have challenge tests, of course, that we challenge our patients with the causative allergen to see how is the response. We also have the work or the help of the of the laboratory, and we can measure the specific ID, well, in single form, what we call single plex, or in multi-platforms that we call multiplex. And we also have some cellular assays that actually can provide other kind of information, as we will see later. Actually, this has been recently reviewed, and you can download from the World Allergy Organization journal. It's open access, and it's all the tests regarding allergy diagnosis. Well, what we can do in the laboratory, here is the representation of the sensitization phase plus the immediate and delayed allergic reaction. And well, we can measure almost all cytokine patterns nowadays. We can measure the specific ID that is produced. We can measure also how the cells are activated, and also how they, also the products that are released by those cells. Actually, nowadays, we can probably measure almost all soluble mediators that are in the allergic reaction. Well, we will now concentrate in the specific ID, the measurement of a specific ID. Well, we have the allergen that is bound to a solid phase. Then we add the serum of the patient, and later a tracer that we will determine the quantity of a specific ID that the patient has. And there are different methods. They have been actually in cellulose, in paper, even in liquid phase. There are very, well, a lot of different systems just to measure the specific ID, mainly in single form. Also, another way to do is to run a polyacrylamide gel and then transfer into nitrocellulose with this Western blot. And actually, we have here how after running the gel and in the paper, we can add the antibodies and also determine according to the molecular weight which are the different allergens. Here we have an example of some allergens done in immunoblot. Well, but we usually in allergy always have one problem that is very typical, is that we have polysensitized patients. Patients not that they are not only sensitized to one allergen. Here, apparently, we have two patients that are exactly the same according to the prick test. So those both patients are allergic to grass, olive, tree pollen, paritaria pollen, peach, and apple allergen. But when we just check the molecules, we see that both patients are completely different. The first one is sensitized to 15 different proteins. Meanwhile, the patient 2 is only sensitized to 3. But these 3 proteins, they have cross-reactivity among pollens, cross-reactivity among pollens and foods, or just cross-reactivity with foods. And what means cross-reactivity? Well, is that we have one allergen, but it's present in 2 different sources. And we have to distinguish this situation from the co-sensitization. The co-sensitization is when we have 2 different molecules, but they are in 2 different sources. And that is why the patient is sensitized to 2 things, not to one that is shared in 2 sources. Well, when the cross-reactivity happens, mainly when proteins that belong to different sources have similar structure, and then the IG recognize both. And this is usually with different affinity, and that will be also very helpful. And we will put an example. We are in the clinic, and the patient just tell us that the patient feels reactions when they eat some spices, also when they are exposed to different trees, different vegetables, hazelnuts, fruits. Well, here we see that is B1. We will check the next one, prophyllin. Actually, the patient complains almost the same: nuts, tree pollen, grass pollen, fruits, vegetables. And even the third case, the patient complains almost about the same triggers: nuts, tree pollen, weeds, the pollen of trees, lettuce, cereals, fruits. Which is the difference? Well, they are very important difference. We know that most BET-B1 sensitizations and prophyllin sensitization, usually the primary sensitization is respiratory, and they usually only produce oral allergy syndrome. So it's a mild itchiness in the mouth, and usually is not associated to severe reactions. But the LTP, where the sensitization is mainly digestive, actually usually they are associated with severe anaphylaxis. So it's very important to distinguish when the patients apparently they are complaining about the same triggers of the symptoms, but they are so different. How we can do it? Well, with the molecular diagnosis, it's very easy. Immediately we know towards the patient is sensitized. So immediately we know if the patient is sensitized to the BET-B1 homolog, to the profilin, or to the LTP. And this is one of the important use of the molecular allergy diagnosis. Well, before, how we were just doing the cross-reactivity studies? Well, doing RAS or immunocap or blood inhibition. But as you can imagine, these tests are not so accurate as the modern knowledge with the molecular allergens. Well, this is how it was performed, the test, and it was a competition between the allergen that was bound to the solid phase and the allergen was in the different dilutions in the solution of the test. Well, the allergy diagnosis has increased very much, of course, since the discovery of the IG, and in the in vivo test started much before, but in vitro tests after the IG was characterized in the 67 and start with the first test like the RAS, the allergy absorbent test. And later there were the appearance of some recombinant allergens, and finally we have the component resolved diagnosis and also the molecular allergen with the different methods that we will review later. Well, the important thing is that nowadays, what mean to be allergic to grass? We have not to say you are only allergic to grass. Nowadays, we have to say you are allergic to these specific proteins of the grass, because we need much more knowledge. Even with the knowledge of the molecular allergen diagnosis, we are able even to compare the different extracts that we have in the market to use, for instance, in this case, for Timothy grass. As you can see, all the extracts are so different. And if we just go to measure the proteins, for instance, the extract 1 is only having 40 from the phleum P5, meanwhile the extract 4 have 783. So what is the important thing? The extracts are not exactly the same from every different manufacturer, and also it's very important that we use extracts that are adequate to the region where we are living, because also the different concentration change according with the different areas, and also the sensitization of our patients. Exactly the same for the mites. In this case, we have 8 manufacturers, and you can see there is great difference among the different concentration of the different proteins of the extract. So that's why this is very important, and this also has been recently reviewed in the consensus that we published in the World Journal, and it's also open access to try to understand how works the molecular allergy diagnosis. Actually, we are just also entering in the multiplex technology, because usually the molecular diagnosis we can do, of course, in singleplex, only one by one, but usually it's done in multiplex platforms. And what is the difference between the singleplex and multiplex? Well, usually the singleplex is they have much more quantity of allergen, is only one by one, and we need a lot of serum because we need 50 microliters for each sample, and that is, we have much more experience. Meanwhile, the multiplex, we can get up to 112 results. For instance, in one of the chips, there is another chip that it contains almost 180. There are other methods that we will see that contains 250. And the total quantity that is used of serum is just 40 microliters. So it's much little quantity for all the allergens. Of course, this method is semi-quantitative. So these are the major differences between singleplex and multiplex platforms. But what gives us the multiplex platforms here is that we just add these 40 microliters, and we are able to see these results, and we can really find which is the positivity to the difference. So what we can do here is a picture of sensitization of the patient. Other methods is just artificial bloods, where they are bound different proteins, and we can just do specifically for different problems. For instance, here we have one that is for pediatricians, who contains the major allergens, molecular allergens of egg, milk, and peanut, or this for insect venoms that contains for bee and also for the wasp, and or this for Timothy grass and birch, etc. So another method is the ALEX, and it contains 282 allergens, 157 are extractive, and 125 are molecular components. Well, this is a methodology that is very nice, and use also nanoparticles. And the important thing is that we will get also the picture with all the information of the sensitization of the patient. So we also have another test that we would like to mention today, are the cellular assays and when we have to use it. So we know that we can measure, of course, not only the products or the mediators that are released from the mast cells and basophils, but also the change that occurs in the cell surface of those cells. So we know that the symptoms, when we just here, we have the representation of the nasal challenge test, and we have the kinetics, and we have the symptoms are induced in 30 minutes, and they are mainly by the histamine, the effect of the histamine. Later, we have the second phase that is mainly induced by the leukotriene products, and also the derived products from the eosinophils. But it's very important that we are able to measure histamine. So we do an allergen incubation just in the tube, or and then the cells become activated if there is a specific reaction, and the histamine is released. Okay, we just do a cure in which we count the total that is induced with the maximum release, and also the basal, and we are able to do a cure and to see how the different allergens are able to produce different release of histamine. Well, this method is a complication only because it's very difficult to work with histamine, because the life of the histamine is not too long and it's a little complicated. Much easier is to work with the production of sulfuryleukotrienes, because the supernatants can be kept and then measured later in ELISA, and there is another method. But I would like also to mention actually the basophil activation test, because nowadays it's growing and it's very important. The problem that we have is the basophils are the main refraction of the leukocytes, but with the flow cytometer we are able to analyze every single cell, and that's why we can induce objective, sensitive, precise, and reproducible results with very low number of cells. That's why flow cytometry is so important. Actually, what we do is we stain the cells with some fluorescence and antibodies, and then we can just convert the leg signal into digital signal. And this is what is happening in the basophil activation test. Okay, we know that the basophil, when they are non-activate, even if they are wearing on the cell surface a specific IG, but there is not anything that is cross-linking, so there is no allergen, there is no anti-IG, the basophil is resting. And when the basophil is resting, it's not expressing any of these molecules on the cell surface. But if the basophil is activated because there is the presence of an allergen or an anti-IG, of course there will be the release of mediators, but also there will be a change in the cell surface of the basophil, and those basophils will start to express these molecules. This is what we are measuring in the test. So here we can see how basophils are activated in 67% in this sample. And this test has also another advantage. Doesn't matter if the basophil is activated by allergen, anti-IG, or by non-IG mediated, like for instance, happens with the aspirin. So we know that also aspirin activates the basophils, and also the basophil become CD63 positive. So this is very important. This is an example how a patient with two different concentrations has almost 80% of the basophils activated after aspirin exposure. Well, which are the validated tests in allergy? Well, without doubt, the clinical history. Of course, we have the diagnostic tests that we have seen for IG mediated, for non-IG mediated, like the test that we have seen right now with the basophil activation test. We can have, of course, all the tests, the quantification of the IG, the cellular test, also the use of molecular allergens, and the challenge test. But what we can do now with all these tests? Well, we can just start to work in precision medicine. Well, usually precision medicine and personalized medicine has been used in a very similar way, and it's not exactly the same because precision medicine is focused on the endotype, on the mechanism of the patient disease, meanwhile the personalized medicine is focused on the patient, on the person itself. And we know that before we were just doing treatments that were just with the same treatment fits all, but now we are doing with the precision medicine to do phenotypes and give to every patient specifically what the patient needs, and later also even more specific doing personalized medicine. Well, phenotypes. Well, the phenotypes are just artificial classifications that we do. And for the phenotype, to do a phenotype, we need a genetic makeup and environment. In this case, we have 2 cats, and they are genetically different. That's why they have different ears. One, they have curling ears, and the other hand has normal ears. But this is genetic. In this other sample, they are exactly the same from the genetic point of view, but depending on what they are eating, of course, they will also affect the phenotype. So depending on the environment, and both things are really conditioning the phenotype. But in practice, for the phenotyping, we can use a lot of things nowadays. We know a lot of technology, genomics, epigenomics, transcriptomics, proteomics, but in reality, we are just still using some exposomics. We also evaluate the patient, and we do some lung function tests, because the others are a little for research at the moment, but probably in the experimental level will be incorporated in the future, or in some cases. We are always looking for a good biomarker that will help to phenotype severe asthma. Okay, so yesterday we say that one size fits all. Then we went to stratify medicine with the phenotypes, and we are going to the personalization just with the precision medicine, just giving exactly the best solution to every patient. So for having precision medicine, we need to identify the mechanisms, and also we need to have specific diagnostic tools to understand those mechanisms and to have specific treatments to block that. And here we have the representation of the different monoclonal antibodies, those that they contains that are chimeric, that contains the C in the word, or they are humanized, then they have Su, like omalizumab, or the ones that are humanized that contains only U, like for instance dupilumab. So they are examples of those antibodies that are used in precision medicine. The fact is that we are able to specifically block some mechanisms. And also here, the allergy diagnosis is very important to treat severe asthma, mainly when we have a T2 profile. So what we know is that before ordering any biological, we have to do several questions. Is it asthma? Is well treated? Is the patient suffer other risk factors, other comorbidities? Is really a high type 2 phenotype? We have measured all the things to be sure that it's a T2. And also we have tried other treatments before the biologicals. Well, if we have fulfilled all these criteria, then we can start with the biological for severe asthma. And in fact, Gina proposed 3 major branches, that is the anti-Ig, the anti-IL-5, and the anti-IL-4 receptor that blocks IL-4 and IL-14. Well, the biological targets, as we have seen, here we have the representation of the stimulation via Th2 and ILC2 that we have seen before, and we see how IL-4 can here is important in this participation, and also in this enhancement of the response. So blocking at this stage will be important, but also when we start to activate the eosinophils, blocking the IL-5 will be so important for just not calling the eosinophils, but also later once we have the eosinophilia to control the eosinophilia. So these are the major effectors that we have on the immune system. Well, we will just check. We have anti-Ig also, because Ig plays a very important role, not only in allergy, but also in some cases of severe asthma. And of course, we have the anti-IL-5 that we mentioned, and the anti-IL-4 receptor that we will see later. Well, IG, we know that it is important and participates in almost all parts of the inflammation and in all phases, and also is actually really given participation to many cells, like the basophils, dendritic cells, eosinophils, macrophages, mast cells, and neutrophils. And the first monoclonal antibody that was important for treatment of severe asthma as an anti was omalizumab, and actually is acting at different levels. So we can see that the omalizumab sequesters the free IgE and prevents IgE binding to the epsilon receptor. Also dissociates the pre-bound IgE that is bound to the mast cells and basophils. And we also know that when it's free, the complexes can trap free allergens, but also will induce B cell allergy. So there are different mechanisms that are working on omalizumab. Well, we already mentioned that we have a type 2 inflammatory disease and they affect different diseases. So we could always say that we have the same immune response in different disorders. And mainly we have the effects on the eosinophils. And here, the eosinophil plays a very important role in severe asthma. So we have effects on the T cells, on the neutrophils, on the macrophages, on the mast cells, on the basophils, on the dendritic cells, also plasma cells, B cells. Actually, they play an important role. And they are mainly activated and really enhanced by the effect of IL-5. That is why if we block the IL-5 with any of the ways that we have, well, blocking directly the IL-5 with the reslizumab or mepolizumab, or blocking the receptor with the benralizumab, we will have a decrease. And this is the second strategy approved by GINA. So we have that the anti-IL-5 actually reduced activation and survival of the eosinophils. And this is another mechanism that is important using the allergy mechanisms to control the disease. Well, another important factor is when we block the receptor of IL-4, and the receptor IL-4 will block the effects of IL-13 and IL-4, and actually this will help also to control the effects because they have the same pathway and they are overlapping functions, and actually we know that the dupilumab is working just doing this effect, reducing the pro-inflammatory cytokines, chemokines, nitric oxide, and the levels of IgE. So, as we can see, the allergic mechanisms in asthma are so important. So, and the type 2 inflammation will be responsible for the decreases observation of hospitalizations, the overuse of oral corticosteroid use. That's why the biologicals will help just to reduce this overuse of oral corticosteroids. Also will induce the reduction of the lung function, also the reduce of the quality of life, and also increase all the type 2 inflammatory comorbidities. And finally, we've just talked about the precision medicine, the allergy diagnosis, and importance for the allergen immunotherapy. We have already seen that the allergen immunotherapy is the path to precision medicine. Well, it seems that precision medicine is something new, and probably those that we have been doing immunotherapy for so many years, we have been doing personalized and precision medicine without knowing, or at least without knowing the name, but we were doing without doubt. Before, we were just given the precision medicine. But in the future, it will be very important if we are able to have a biomarker to identify which of the patients that we have will respond to immunotherapy. The fact is that according to the Hamburg and colleagues, to talk about personalized medicine, we need to identify the molecular mechanisms of the disease, and we know how is the molecular mechanism of the allergy response. We need the diagnostic tools for molecular mechanisms, and we have been talking today about the diagnostic tools that we have, like the ID to the causal allergen, the component detection, and we, of course, we need the treatment, and also the treatment is the immunotherapy itself. Well, for molecular mechanisms, we already know that when we do immunotherapy, the effect that we really the effect that is obtained the very fast is the early decrease in the activity and responsiveness of some effector cells. At the beginning, there will be an increase of the specific Ig, but later will be a decrease of the specific Ig towards the allergen of the immunotherapy. There will be a switch, so the Th2 will be decreased and the Th1 will be increased. We will have the induction of T-regulatory cells, and we will also have the induction of some antibodies of the isotype IgG, mainly that will act and serve as blocking antibodies for the response. Of course, we have the diagnostic tools. We have been talking today about the validated tools for immunotherapy. Of course, the clinical history, the test, skin test, the measurements of the specific Ig, the use of molecular allergy diagnosis, the CAP inhibition that is a little limited, and other tests that we have mentioned, like the basophil activation test or some provocation tests. And probably in the future, we will just talk about genetic studies, phenotypic studies, and the omics. Well, and the treatment without doubt is the immunotherapy. And we know that for the immunotherapy, it's very important that if we have a patient with a good clinical history and the test that is so clear that is positive, of course, we will go directly to immunotherapy. But if we have doubts or there is not a single allergen, we may run the molecular allergy diagnosis. And if we have up to 2 causative allergens, we will perform immunotherapy. If we find more than 2 causative allergens or more than 2 sensitizations, we need to distinguish and determine which of those sensitizations are the important ones. And once we are able to do it, we will just go towards immunotherapy. At the end, what we have is to use the precision and the personalized medicine. So always together with the patient, we have to discuss which is the best route of administration, subcutaneous, sublingual, or other uses now we have now, like is intralymphatic or other ways in the epicutaneous, the dosage, the schedule, the cost, how is in every single patient. At the end, what we have to reach is what is the best for the patient. And which patients for immunotherapy? Of course, those patients that have appropriate clinical manifestations, that they have a demonstrated Ig-mediated mechanism to the relevant allergens, that they have a significant exposure to the relevant allergen, and of course that we have availability of high-quality strains for the relevant allergens. And again, the use of the molecular allergy diagnosis is crucial. And we will see here this example. This was published by Salvatore Tripodi. And here in yellow, we have the sensitization profile of the patient. And in blue, we have the immunotherapy that we are providing to the patient. Well, in this case, the sensitization and immunotherapy that we are providing match completely all 4. So, but probably this only will represent 4% of our patient. So it means that we have 96% mismatching. What is the problem? Many times the patient is sensitized to more molecules. For instance, the 4 that has not been included in the immunotherapy. So we are not doing immunotherapy for the group 4. Or we have a patient that is monosensitized to just one group, like the group 1, and we are giving for free 3 extra groups in the immunotherapy. Or we have one that is in the immunotherapy and other that is outside immunotherapy. So we are just only giving for the 2, but the 615 was not necessary, and we are not giving to the 4. If we see here, more than 90% are those cases of mismatching. And this is the worst mismatching, when no one of the allergens towards the patient is sensitized is included in immunotherapy, and that represents 5%. So what is the importance of this? Well, several studies like this of Carmen Moreno, that patients that were actually receiving immunotherapy for olive tree, for grass pollen, or for both. Well, after doing the molecular allergy diagnosis, those that they were receiving both grass and olive tree, probably only half of them required to have such kind of immunotherapy. And probably they were much more than needed just to receive only grass and only olive. So there is very important information with the molecular allergy diagnosis. This is another study that published by Joaquin Sastre, and you can see that almost 50% of our patients were not receiving appropriate immunotherapy once the molecular diagnosis was performed. And also in Italy, it was a multi-center study that they checked. And just for make this a long story short, in Italy also they found that 47 of the patients that they were prescribed immunotherapy based on the skin prick test after doing the molecular allergy diagnosis, 47% probably they changed the prescription. So it's very important that nowadays we do molecular allergy diagnosis for doing appropriate immunotherapy. And how we do is because we need to determine which are the genuine allergens versus those that they are cross-reactive. And this is very important. And this is how the molecular allergy diagnosis has to be used for a specific immunotherapy. So which is the use of individualized allergens? It allows the specific identification of the allergenic molecules involved in the clinical reaction, will help to identify the polysensitized patients, and also to determine the sensitization patterns of every different regions and different areas. It will also help us to be as severity predictors, because we know that maybe in food allergy, some allergens are associated to the severe reactions, meanwhile others are just associated to very mild reactions. So it's very important to discriminate between sensitization and clinical reaction. We are able to establish diagnostic algorithms and also the relevance in the allergen immunotherapy. So what we have to do for every patient with a molecular allergy diagnosis is to have this picture. Which are the molecules that the patient is sensitized that are associated to the high risk, and which are those that are associated to the lower risk. And with this picture, we can just take the decision together with the patient for the future. So for take-home message, we can say that the most important diagnostic approach, without doubt, is the clinical history. And it is necessary to have a complete picture of the allergen positive sensitization for an appropriate diagnosis. And the precision allergy molecular diagnostic application, the PANDA, is of great value in composing an appropriate blend of allergen for more accurate diagnosis in every patient. And I would like to thank all of you for the attention. And I hope that we have give just an overview of the allergy diagnosis and the importance in the allergic respiratory disease. Thank you very much for your attention.
Thank you again, Professor Ansotegui, for your very nice presentation. Indeed, it was, to me, puzzling, the last couple of slides showing when we prescribe immunotherapy just based on skin tests with an allergen extract, we might be treating patients unnecessarily.
Yes, well, it's true that these slides that you have seen, just using the molecular allergy diagnosis, how change the prescription are important, but we have to think that those are important in polysensitized patients. For those patients that they are so simple, that they are clear allergic, for instance, to the house mite, and they are positive in the skin test and positive in just with the test, with the single plex, with the specific IG, is more than enough. Of course, in those patients, it's not necessary to run the molecular allergy diagnosis. Only in those patients that are polysensitized with a lot of different allergies are very important.
Okay. Do you treat with immunotherapy all allergens the patient is sensitized to?
No, actually, this is probably one of the differences that we have from other parts of the world regarding Europe. In Europe, we only treat those sensitizations that induce symptoms. So in other words, we just treat the allergens that really creates allergy, not just the sensitizations. Because in fact, we have seen that many times the sensitizations are due to cross-reactivity. And in fact, what we are trying is to avoid to do immunotherapy for cross-reactive allergens. What we try is just to do immunotherapy against genuine allergens.
Yeah, thank you. Let's see if we have another question here. Ignacio, could you comment on the basophil activation test? Because it is a test that is suitable for IgE-mediated reactions and also non-IgE-mediated reactions?
Yes, it is suitable for both, for IgE and non-IgE mediated reactions. But again, this test is a little complicated because to work with fresh basophils is not so easy. It's always complicated and it requires a lot of training and it's difficult. So this test usually is kept, for instance, for drug allergy and other ways that we have some doubts. So it's not a routine test to use every day in every single allergen. So it's more when we have specific doubts or we need non-IgE mediated allergy.
Great. Another question is on immunotherapy. How could the allergy or molecular allergy diagnosis to help choosing which is the best route for immunotherapy? Is it sublingual? Is it subcutaneous?
Well, this is always that we have to talk with our patients. We have to sit down and consider if they are able to attend the clinic in case that we are prescribing subcutaneous, or if they live very far and it's very difficult to attend any hospital that could do the immunotherapy. Also will depend of the age. I mean, one of the problems that we have in allergy usually is the adherence. And also in asthma, one of the problems is the adherence to the treatments. Imagine to take some tablets or some drops for something that is curing you at a long time, a long range time, when even the same people, even they are not taking the inhalers that are opening the airways in the moment. So one of the problems is if the person will really perform the immunotherapy. In this way, we usually prefer, for instance, for teens, we prefer to use subcutaneous because we know that they attend the clinic. It's the only way that we can control it.
Yes, I agree. Compliance with the sublingual tablets or drops are not as well attended as subcutaneous because you see the patient, you inject the patient. So that's much adherent to treatment than putting the sublingual stuff every day. I don't see any more questions. Professor Ansotegui, would you like to make your final comments?
Well, I think that the allergy plays a very important role in many respiratory diseases, of course, mainly asthma. And always we have to work also in the immune system just to help well, as a treatments, immunotherapy or biologicals, just to modify the course of our diseases. So this is the message, and I think that we are now in the good way, and probably we will have much more biologicals in the future, and also better ways of immunotherapy.
Yeah. I just want to thank once again the Global Asthma Association, Interasma, for the invitation to moderate this very, very nice session. I think it's enjoyable to hear Professor Ignacio Ansotegui and bringing so many informations, new informations that may change our way to evaluate and treat patients. Thank you very much, Professor Ansotegui.
Thank you to all of you. Thank you.